My name is Janice Louie, and I am the medical director of the TB clinic at the San Francisco Department of Public Health. And I was asked to come and talk about the trends in TB in San Francisco during the COVID-19 pandemic. So I have no conflicts of interest. And so let's start with the bird's eye view of TB in the United States. So this data is from 2019 because this was the last year of full reporting pre-pandemic. And in general, the US is considered a low incidence country with regard to TB, with an incidence rate of 2.7 per 100,000. Now, California is considered a hotspot at 5.3 per 100,000, and San Francisco is considered super hot at 11.9 per 100,000. Here is who we treat for TB in San Francisco. Our median age of cases is 64 years, and in fact, we treated a 101-year-old in 2020. Half of our cases are over 65 years of age, and 86% are non-US born, including 3/4 coming from Asian countries, including China, the Philippines, and Vietnam. Over 80% have been in the US over 5 years, which means we think that most of our active TB is due to reactivation and not to recent transmission. The TB case rate in Asians is 17.3 times that in non-Hispanic white populations in San Francisco. So San Francisco felt the effects of COVID-19 long before the first cases were identified. And that's because we are considered an international port of entry, especially for the Pacific Rim. And this is seen here where we averaged pre-pandemic nearly 23,000 passengers annually from Wuhan alone into San Francisco International Airport. So in late January, the CDC began to issue progressive travel advisories and recommendations, including that incoming travelers from Wuhan and then mainland China needed to screen for COVID-19 symptoms upon entry, and later to include that any travelers coming from mainland China needed to be in quarantine for 2 weeks. This resulted in a dramatic drop in travelers incoming from China into San Francisco. Our local leaders were quite progressive. In early March, the first 2 COVID-19 cases were identified who did not have an epidemiologic link, which signaled community transmission. And later in mid-March, we had orders for shelter in place and for deferral of routine medical appointments and elective surgeries. So this resulted in a dramatic drop in new TB diagnoses and B notifications in the first 4 months of the pandemic. And so that's reflected in this figure here, where the white bars represent total active TB cases on treatments, the gray bars represent new active TB evaluations, and the black bars represent B notifications, which are new immigrants who are coming into San Francisco with evidence of TB on X-rays overseas. And so you see that in the 2 years pre-pandemic compared to 2020, the numbers markedly decreased to 40% of our baseline levels. This decrease in TB notifications was later borne out to be occurring worldwide throughout the end of 2020. And in fact, WHO recently issued a report noting that the number of new diagnoses of TB dropped from 7.1 million to 5.8 million, or 18% from 2019 to 2020. And so reasons why this may have been happening both in San Francisco and globally is that there is likely a large shifting of TB clinical and laboratory resources from TB to COVID-19. And in our own setting in San Francisco, about 30% of our staff were diverted. We think shelter in place had a huge role. We also think that limited access to or fear of using healthcare services, clinics, urgent cares, ERs contributed, including a loss of employment-related health insurance to access any primary care and evaluation of symptoms. To that end, for those frontline providers in ERs and urgent cares, there's an overlap of symptoms and signs and radiographic findings for COVID-19 and TB, and likely they were very much focused on prioritizing COVID-19 screening over thinking about TB. Finally, there is fear and stigma, at least here in the Bay Area, where we have had reports of anti-Asian hate crimes happening since the beginning of 2020, and that has extended through the current month, and that likely kept much of our population staying at home. So we performed a look 19 months in to see what was happening now. And we divided it into two periods based on what was happening pre-pandemic. So from January 2019 through March 15, 2020, and then during the pandemic and beyond. So from March 16, 2020 to this current month. So as a reminder, TB is reportable in San Francisco within 1 working day, and our clinic manages all SF residents who have suspect or confirmed active TB. And for all fatalities, we conduct a standardized review to identify whether that death is TB related. So let's review this busy figure, which shows TB trends in San Francisco during the pandemic. And so let's go over what we're looking at. The line at the top is total TB cases on treatment by our clinic from month to month. The gray bar is new TB cases diagnosed. The black bar is new TB cases that required hospitalization at diagnosis. And the striped bar is new TB cases who died in that month. So you'll see that what we considered pre-pandemic, prior to March 2020, when that shelter in place order went into effect, we had a lot of activity, but most of our cases were not presenting hospitalized or dying. And then between March and July of 2020, we had a lull in cases as shelter in place really took effect. And then with the vaccine coming in December 2020, and then progressive loosening restrictions in San Francisco, we saw an increase in activity. But what we think we're also seeing is that as activity has increased, a large proportion of our cases have been presenting either hospitalized or with such severe disease that they have died from TB. And that's reflected by the black bars relative to the gray bars and the striped bars relative to the gray bars. So looking at it from a numbers standpoint, again, the two different periods are pre-pandemic shelter in place and during the pandemic up to now. We averaged pre-pandemic 7.9 new TB cases per month, and during the pandemic, 5.9 new TB cases per month. The median age of our cases did not change. However, disconcertingly, the proportion who required hospitalization increased from 33% pre-pandemic to 56% during the pandemic. And the number of cases who died due to TB increased from 3%, 3.5% pre-pandemic to around 12% during the pandemic. We don't think that concurrent infection with SARS-CoV contributed to this because almost all patients were screened at diagnosis of TB, and only 3 patients were subsequently confirmed to have SARS-CoV-2 infection with TB, and all were diagnosed more than 2 weeks after their first diagnosis of TB. So we think these TB deaths were truly related to TB only. We looked at other factors, and we did not find a difference between the two periods with regard to proportion who were non-US born, cases who used alcohol or substance use, cases with a mental health diagnosis, or those who had presence of a cavity. However, what we did find is a difference in the proportion of TB cases who were homeless or marginally housed. It went from 5% pre-pandemic to 15% during the pandemic. This makes sense if you've been following the news in San Francisco, where the closing down of shelters and limited capacity of many shelters resulted in large tent encampments that were sponsored by the city. And many of our residents also pushed into marginal housing, such as single residence occupancy units, where they often had shared bathrooms and shared kitchens. So we also saw a drop during the pandemic in supportive services for this population, which included alcohol and drug rehab, case management, social worker, temporary housing. And it's likely that these outdoor encampments were very crowded, as were the SRO settings, which may have contributed to increased transmission of TB. So this is actually a familiar pattern. Increases in TB mortality have been observed historically in many pandemics, including in 1918 in Switzerland, with the 2001 SARS outbreak in Hong Kong, with the Ebola outbreaks in West Africa, and with the 2014 MERS outbreaks in Saudi Arabia. And in fact, early in the pandemic, the Stop TB Partnership predicted, based on a modeling analysis, that a prolonged disruption in TB services could result in an additional millions of cases of active TB and TB-related deaths over the next 5 years. And so this prediction has actually borne out. Unfortunately, WHO recently released a report that noted that TB deaths rose for the first time in over a decade due to the COVID-19 pandemic. The numbers went from 1.2 million in 2019 to 1.5 million in 2020. And TB is likely going to be the second leading cause of infectious disease death globally after COVID-19 in 2020. Other concerning trends include that the number of people reported to be on treatment for TB disease, including for MDR TB and also for preventive treatment for latent TB, have all dropped in 2020 compared to 2019, which again likely reflects a diversion of resources that used to support TB diagnosis and treatment over to COVID-19, as well as, again, restrictions as far as congregate settings and gatherings and going to healthcare settings. So what are we doing here in San Francisco? Well, we have been working to intensify case finding and outreach to frontline healthcare providers in ERs and urgent cares and hospitals, and reminding them that the signs and symptoms of TB, as well as the radiographic findings, can mimic those of COVID-19. We've increased home-based care with our providers going out into homes for our patients who want to stay sheltered in place. We've scaled up contact tracing and SROs. We're working to expand our video and telehealth capacities, a little more challenging in our population of both older persons, non-US born, non-English speaking, and those who aren't housed. And most importantly, we're trying to promote that our TB expertise is a valuable skill set that can be used to build infrastructure for other communicable disease outbreaks so that we can build a sustainable workforce that can both tackle TB as well as other outbreaks in the future. So I'm going to stop there. Thank you for your time, and I am happy to take questions during the next period.